Hey everybody, welcome back. Today we're going to continue on with the respiratory bacteria. So, H. influenza is a gram-negative, catalase, and oxidase-positive organism. It's technically a bacteria. It's only called Haemophilus influenza because it was first collected from patients who were infected with the influenza virus. So, being that it is a bacteria, it's a non motile rod, and that it is capsulated or non capsulated or non typable. So, it's a pretty picky bug. It requires both factor X and factor 5 to grow, and the capsular type B is the most virulent of all the strains. All the capsular types have the hexose sugar capsule, but type B is the only one that has the pentose sugar capsule that's made out of a polyribose ribitol phosphate. It's a human pathogen, and it's going to be transmitted via respiratory droplets, and the risks are going to be children and unvaccinated people. So the IgA protease helps with the colonization due to the dissolving of the mucus and just breaking apart the IgA, so there can't be a cellular response. The other factors are the pili and the non-pilus adhesions, which allow it to attach to the host cells. And it also has the endotoxin, which is a lipooligosaccharides, which is really similar to the Neisseria toxin. And it is going to first adhere to the ciliated cell, and it's going to kill the ciliated cell. So the cilia is not going to be able to push the pathogen outside the body. And due to the toxicity, it's going to induce inflammation. So meningitis is going to be caused by type B. The ear infection is going to be caused by non-typable, so it's uncapsulated. Sinusitis is also caused by non-typable. Epiglottitis is also caused by type B. Tracheobronchitis is going to be a non-typable. Bacteremia is type B, and pneumonia is going to be caused by non-typable. So as you can see, type B is like the most serious. It's a non-invasive or an opportunistic infection caused by like either the non-HIB or the non-typable strains. It's going to be spread by droplets, and unfortunately, it's an invasive bacteria, so it's really dangerous, particularly in children. Epiglottitis is going to have an acute onset. There's something called a thumb sign where the epiglottis is really inflamed. It looks like a thumb poking backwards. It can obstruct the airway, cause dysphagia, dysphonia, drooling, and distress. It's characterized by stridor and a cherry red erythematous epiglottis. You diagnose it by putting it on chocolate agar, and it's going to appear as gray colonies. They are also put on a blood agar with a Staphylococcus aureus streak, and that allows for the satellite growth where the Staph aureus is going to produce the factor 5 or the factor 10 and allow stronger or more prolific growth around those areas. In the latex agglutination, it's a positive for only H. influenza type B. And the treatment for it is either a cricothyrotomy to maintain the airway, or amoxicillin, doxycycline for a mild infection. And for a severe infection, you want to give a broad spectrum cephalosporin. So we are lucky enough that there's a vaccine for it. The vaccine for the type B or HIB is the Brp vaccine, and that is conjugated to the diphtheria toxoid or the tetanus toxoid. Since it's a conjugated vaccine, you need multiple boosters. And for people who are living in crowded areas, places that are kind of rampant with H. influenza, there is rifampin given as a chemoprophylaxis. Chronobacterium Diphtheria is a gram-positive bacteria, and it's club-shaped, and it undergoes this snapping division where it is going to be arranged in either V or L shapes, and it forms these volutin granules, and it gives a little beaded appearance, as you can see here. It's a metachromatic stain, so the granules are going to be red-purple while the rest is blue/green, and the reservoir is going to be the nasopharynx in humans, the upper respiratory tract, the GI, or the skin. So it's an asymptomatic and, part of the normal flora critter until it gets the toxin gene from the phage and become lysogenized. So this, along with the strep pyogenes or Klebsiella pneumonia, it needs the phage to infect it to become contagious. So the transmission is going to be through the respiratory secretions. There are the pili or the fimbriae that help with adhesion, and it has an AB exotoxin, and it's going to bind to the heparin binding epidermal growth factor and inhibit the protein synthesis via the ADP ribosylation and inactivate EF2. So the regulation via DTXR, which is an iron-dependent repressor, is going to respond to tissue iron levels. And at low levels of iron, the protein is going to de-repress the toxin gene, allowing it to start producing more toxins. But high levels of iron will activate the protein and repress the gene, so no toxin is going to be made. It incubates for 2 to 6 days, and eventually causes a sore throat, arthralgia, fever, dyspnea. And in the local inflammation, there's going to be greenish, whitish, fibrous exudates that form a pseudomembrane, usually on the soft palate. The exudate is going to be filled with neutrophils, necrotic epithelial cells, erythrocytes, and bacteria in a fibrin mesh. And it's hard to remove without damaging the underlying tissue. There is a characteristic called bull neck due to the enlarged bilateral anterior cervical nodes and edema of the soft tissue of the neck. And the skin diphtheria is going to manifest as these vesicles, which eventually erupt or burst into ulcers. They are more common than respiratory diphtheria, but it's very hard to treat. The more important complication is the myocarditis, because that can affect the heart long term, even after treatment. And the most concerning part of diphtheria, especially short term, is the airway obstruction, because a patient can die very fast from that. Other complications include the arrhythmia and the circulatory collapse, along with the nerve weakness or the paralysis of the cranial nerves, and that can cause the paralysis of the soft palate and the pharynx, and then the regurgitation of the fluid. There's going to be difficulties with vision, speech, swallowing, and movement of the extremities. How do we diagnose it? We give the gram stain along with a methylene blue stain. On the culture, you use either the blood agar in order to see the gray irregular colonies, the Tinsdale or Tellerite medium, which makes the gray-black colonies, and the Leffers serum plate in order to make granular formation. You can also do a toxin test, also known as the LX test or a PCR. So you want to give the antitoxin as soon as possible, and the penicillin or erythromycin. We do have the vaccines for it, so DPT, not really used in the States, but DTaP, DT, we don't really use DT in the States either, but DTaP, Tdap, and the TD series is commonly used here. And of course, there is going to be some boosters. So the Bordetella pertussis is going to cause the whooping cough, and it is going to, like, you should really look it up. It's a very distinctive kind of cough too. Croup is more like barking, and the whooping cough, there's going to be like a kind of whistly breath before violent coughing. So it's a gram-negative, a strict aerobe, of course, because it infects the upper respiratory tract, and it's a capsulated cocci. It is a pretty picky bug. It needs the Bordetella media, and they appear as mercury drop colonies. And it's like a opaque kind of grayish-white, shiny dome, and it's unfortunately resistant to penicillin. So the reservoir is humans. Transmission is through like coughing, direct contact. It's incredibly contagious, and it adheres and multiplies in the epithelial surface of the trachea and the bronchi, and cause increased respiratory secretions, which interfere with the ciliary action. So there is irritation to the throat, along with the bacteria like entering the bloodstream. So the filamentous hemagglutinin and protactin will bind to the integrin on the ciliated cell. Then it's going to bind to the CR3 on the macrophages in order to be phagocytosed without being killed. There, it grows inside the macrophages, which protects it from the humoral immunity. The Pertussis toxin is going to be an AB-type toxin that causes the increased CAMP level, which will increase the respiratory secretion and mucus production, interfere with the early chemokine production and signal transduction, and it's going to prevent the lymphocyte from entering the lymphoid tissue. Another toxin it creates is the Trach Cytotoxin, which is going to kill the ciliated cells. The adenylate cyclase toxin is going to be activated in the host cell by calmodulin to convert ATP to CAMP in order to do basically the same thing. So as you can see here, it will promote the pulmonary hypertension, and it's going to inhibit the lymphocytes from presenting the toxin in the lymph nodes. It's going to reduce the number and the function of the T regulatory sites and suppress the antibody response. So first is the incubation period, and then the catarrhal phase is going to be 1 to 2 weeks. It's going to be that rhinorrhea, along with the malaise, fever, sneezing, is very contagious right now. The next is the paroxysmal, which is going to be 1 to 6 weeks, where there is going to be the whooping cough and the leukocytosis. There is a complication with the leukocytosis and lymphocytosis, where there's going to be increased histamine sensitivity. So in these patients, they can't eat fermented foods, so no beer, no pickles, things like that, along with cured meats, so no ham, no bacon, no smoked fish. The convalescence phase is about 2 to 3 weeks, and that is either the patient gets better or develops the secondary complications, which can involve pneumonia, seizures, encephalopathy, hyperinsulinemia, and it can lead to death. So how do we diagnose it? We use a calcium alginate swab for the nasal swabs, or you collect the cough droplets directly. They can just cough directly on the plate. In microscopy, we label it with a fluorescent antibody to stain it, and culture is to be the Bordeaux Gengao or the Regan-Low, and those need nicotinic acid for growth. Charcoal starch or blood is going to be added to absorb the fatty acid or the toxic substance, and it's a pretty picky bacteria. It grows really slowly. It needs the special nutrients such as the nicotinic acid, and it's sensitive to drying. And so culture may not be a good idea, but we can also diagnose using PCR, ELISA, or a titer against the toxin. How do we treat it? We treat it with macrolides, so erythromycin and azithromycin for the early disease. And for the late stage, it's supportive, so suctioning out the pus, rehydration, oxygenation, and giving some like corticosteroids. There is the vaccine, which is not used in the States because it's a DPT vaccine. It's an acellular subunit vaccine that has a short lasting immunity but less side effects. Multivalent vaccine is going to be the Pertussis Toxin or the filamentous hemagglutinin or the surface protein, so the fibroprotein and the protactin. The Pertussis toxoid is going to be genetically engineered to inactivate the enzymatic inactivity, and then that's going to be given as Tdap or DTaP for children and Tdap for the older children, teens, and adults. So only the DPT is not really used in the US. Okay, so that's it for now. Thank you for your attention and good luck studying.